Sarcoidosis treatment requires careful consideration and understanding. Not everyone is treated, and a clinician should be able to identify cases which requires treatment. So there are conditions in which treatment is started straight away, and getting delayed can lead to potential organ damage. So once treatment is indicated, it should be started as early as possible. But you don't have to treat every patient. For example, patients with pulmonary sarcoidosis are asymptomatic at presentation in most of the cases. And the treatment is only indicated when these patients are complaining of cough, dyspnea, or chest pain, or they're getting short of breath. So the two main indications of treatment are number one, hypercalcemia, and recall that hypercalcemia is associated with variety of symptoms, from abdominal pain to neuropsychiatric symptoms, and the risk of seizures and cardiac arrhythmias also increase with hypercalcemia. So that is why when hypercalcemia is present, it's an absolute indication for treatment. So the next is potential organ threatening. Organs like heart, kidneys, nerves, and skin, whenever these organs are involved, it's an absolute indication that you should start treatment straight away. And delaying treatment in such cases can lead to serious complications. For example, kidney failure, heart failure, paralysis, or disfigurement of the face. So, for the patients who meets criteria for treatment, we use immunosuppressive therapy. Immunosuppressive therapy improves symptoms and disease progression, and oral immunosuppressive therapies such as prednisolone are preferred. They are started and then taper off. And when the symptoms reoccur after tapering, treatment at previous doses can be restarted. So guys, I hope you are with me. So there are certain high-risk features for which treatment is commonly administered. Number 1. Stage 4 radiographic disease. So at this stage the lungs are already fibrosed, and the aim of treatment is to stop further fibrosis and to alleviate symptoms. Number 2. Substantially reduced pulmonary function test. FVC, FEV1 and DLCO. They are the measures of how well the lungs are functioning and how properly the lungs are oxygenating. So when they are reduced, treatment should be started as early as possible. Number 3. Reduced exercise tolerance. So guys, these are some of the clinical scenarios in which the treatment should be started, or if the patient is already on treatment, it should be intensified. For example, pulmonary symptoms are getting worsened over the period of time, such as the patient is getting short of breath on just like taking few steps, or if there is persistent cough, and when there is persistent like a drop in oxygen saturation on pulse oximeter at rest or with exercise, and when there are progressively worsening interstitial opacities on chest x-rays or CT scan, and when there is persistent declining in pulmonary function testing, that is not because of testing variability. So when one of these clinical condition or these scenarios are present, treatment should be started. And if the patient is not on treatment, it should be started straight away, or if the patient is already on treatment, it should be intensified. For example, if the patient is on oral prednisolone, then consideration should be done uh, like to add inhaled corticosteroids. So guys, this is an interesting slide. When there is new diagnosis of pulmonary sarcoidosis, just ask, does the patient have symptoms? If yes, then start steroids straight away. If no, most patients at this stage do not require treatment. Now, does the patient have any of these stage 4 disease? Number 1, stage 4 disease. Number 2, moderately or severely reduced PFTs. Number 3, exertional hypoxia. If yes, then initiate treatment. If no, then monitor only. Approach to patient with suboptimal response. So there are patient population in which, despite adequate therapy and despite like very common compliance, these patient population do not respond adequately, or they have like clinically worsening disease. Patients who require ongoing long-term maintenance, for example, in which the patient cannot be taken off from steroids and constantly taking steroids like 20 to 30 mg for 5 to 6 weeks, or the patients who develop corticosteroids side effects like excessive weight gain, acne, myopathy, and severe osteoporosis. So these are the patients who have suboptimal response, and they must be started on other immunosuppressive agents, for example, methotrexate, azathioprine, leflunomide, or TNF factor inhibitors. So guys, recall our previous slide in which we mentioned that oral prednisolone is the treatment of choice. So the dose started is 20 to 30 mg. 20 mg is sufficient in most of the cases, and the patient are reassessed after 4 to 6 weeks. If there is an adequate response, the treatment is then taper off. As you can see on your screen, there are 86 patients recruited in a trial, and 20 mg versus 40 mg was the goal. So 20 mg was sufficient in most of the cases. Corticosteroids are life-saving medications, and once treatment is one adequate response is observed, then tapering should be considered, as long-term treatment with high-dose steroids can give you very serious side effects. For example, weight gain, osteoporosis, myopathy, acne, abdominal scars, and easy bruising. There are numerous. So the tapering doses are 2.5 to 5 mg every 3 to 4 weeks at doses between 20 and 10 mg, 2.5 mg per day every 3 to 4 weeks at doses between 10 and 5 mg, and 1 mg every 3 to 4 weeks at doses between 5 mg down.
What if the symptoms reappear when the treatment is stopped?
So guys, that was not my voice. So the answer is pretty simple. So if the patient was having adequate control of the disease on the last effective dose, that dose should be continued. For example, if the patient was maintaining good remission on 15 mg per day, so you should continue with 15 mg. Thanks for watching. You can support us by subscribing to our channel and share with your colleagues.